Hi everyone, my name is Brianna Ross, and today I'm going to be presenting the effect of continuous electronic fetal monitoring on birth outcomes in low-risk pregnancies. So I want to start with some definitions because we don't all work in the obstetric world. So I'm going to be shortening continuous electronic fetal monitoring to CEFM, and I'm going to be shortening intermittent auscultation to IA. We're also going to be talking about fetal distress, and when I refer to fetal distress, I'm talking about a category 3 fetal monitor strip, and we're going to dive further into that definition later on. So the objectives of this PowerPoint are to compare the effects of CEFM on birth outcomes to IA, to understand the association between CEFM and cesarean section rates, and to explore the trouble with defining fetal distress as an indication for a C-section. So the rationale for this topic. Currently, there is a lack of evidence supporting the routine use of CEFM during labor. So I work on a high-risk labor and delivery unit. So it makes sense to have CEFM in place during a high-risk labor because there are lots of variables going on with the pregnancy or with the baby that can put the baby or the mom at risk and would require a quick delivery that a C-section could provide. But it gets murky when there's a low-risk pregnancy and we're still using CEFM. So CEFM is associated with a higher rate of C-sections, but despite this, it doesn't actually improve neonatal outcomes. Fetal distress is the most common indication for a C-section. And even when it doesn't end in a C-section, it's still associated with a higher rate of medical interventions in general that wouldn't have been provided otherwise and that come with their own complications. IA, on the other hand, has been shown to reduce the rate of C-sections, and it has no effect on neonatal outcomes. The neonatal outcomes are the same for both IA and CEFM. So why is this important? In 2021, 32.1% of all US births were C-sections. Compare this to the global rate of C-sections in 2018 of 21%. Now, we do have a significantly higher rate of C-sections, and part of that is that we are in a well-developed country with easy access to medical care for most people. It's important to note the World Health Organization used to have a set goal of 10 to 15% of all births to be C-sections. They have changed their stance and they state that they do not have a target rate anymore, but they acknowledge that the rate globally has been inflated by those that are medically unnecessary. And this is a problem because C-sections come with their own complications. And they put both the mother, the baby, and any future pregnancies at risk of developing further complications. So for the mother, big ones are hemorrhage and infection. And there's also problems with wound healing, either in the short term or the long term. Another problem with C-sections is that with every C-section that you have a greater chance of developing what is called a placenta procreta or placenta increta or accreta. So this is when the placenta grows into the uterus or grows into other surrounding organs, and it's a massive hemorrhage risk, which usually ends in a hysterectomy. Additionally, It's not true anymore that once you have a C-section that you will always have C-sections. However, once you've had a C-section, any vaginal delivery that you have after that is automatically a high-risk delivery because there is a chance that the uterus could completely rupture along the scar line during contractions. So as we mentioned previously, fetal distress is the most common indication for a C-section. So what is fetal distress exactly? Well, we define the baby's heart rate into 3 categories. Category 1 is predictive of normal fetal acid-base balance. Category 2 is not predictive of normal acid-base balance. And category 3, which is fetal distress, is an abnormal acid-base balance cannot be ruled out. Now, I want to point out that this does not state that there is certainly a problem with the acid-base balance. It is a suggestion that it is not right. It's not definitive. And it's widely known that this is a problem. It's widely known that EFM has a high rate of falsely positive category 3 strips. So essentially, physicians are performing this major abdominal surgery based on inconclusive diagnostics. So this leads us to our problem statement, the PICO question. In low-risk pregnancies, how does CEFM during labor compared to IA during labor affect birth outcomes? So let's see what the literature says. Alwatar et al. Performed a meta-analysis of randomized clinical trials comparing multiple forms of fetal surveillance and the birth outcomes for each method. They found that IA had the lowest rate of C-sections out of all methods. Once again, no method was found to have a statistically significant reduction in neonatal outcomes. They looked at outcomes such as neonatal acidemia, NICU admissions, APGAR scores, and perinatal death. The researchers are also quick to mention that stillbirth rates have plateaued globally, while cesarean rates continue to climb. Another study by Heelan-Fancher et al. Conducted a retrospective analysis on the effect of CEFM on birth outcomes using birth registry data from 2 U.S. states. They found a 10 and 40% increase, respectively, in C-sections, and a 14 and 24% increase in assisted vaginal deliveries. And once again, there was no effect on infant mortality in full-term and late-term births. They did find in one state that there was a reduction in infant mortality for preterm births. However, they conclude that the evidence to support routine use of CEFM in full-term, low-risk pregnancies is insubstantial. Finally, Wang et al. Similarly conducted a retrospective analysis on multiple intrapartum factors that led to C-sections in one hospital. They found that fetal distress was the most common indicator for a C-section, with 44.3% of C-sections performed for this reason. And this was the most common indicator across a multitude of other variables, such as the age of the mother, any medical history going on, any complications that developed during the labor. Fetal distress was still the most common reason. And again, these researchers point out that fetal distress is a subjective indication for C-section that is largely based on the doctor's experience. And they go on to suggest intermittent fetal monitoring, or IA, and for the definition of fetal distress to be reconsidered in an effort to reduce C-section rates. So, proposal plan. For the patients, this change from going from CEFM to IA would mean a return to patient care. It would likely reduce rates of C-sections and their associated complications. For nurses and midwives, this would mean more autonomy in care, and we would be able to focus more on supporting the patient in labor and in birth. And doctors would need to rely more on the nurse and midwife to guide care rather than the fetal monitor strip. Implementation. My organization, my hospital, would participate in monitoring low-risk labors by either CEFM or IA. We would record the birth outcomes for both surveillance methods, looking at things, again, like NICU admissions, APGAR scores, neonatal acidemia, and of course, whether the delivery ended in a vaginal birth or a C-section. We would need to provide information to the parents or the mother regarding both options for monitoring to make sure that they can make an informed choice for their own care. And some potential barriers to implementing this would be that some women may prefer CEFM because it does relieve anxiety in a way to have this constant reassurance that, oh, look, I can see the baby's heart rate, I can see that they're okay. And similarly, for a similar reason, doctors and hospital leaders might be reluctant to discontinue the routine use of CEFM because, again, it provides the reassurance that everything is okay with the baby, and it also provides a legal defense that if something were to happen, that they did everything in a timely manner to correct the problem. So to evaluate my plan, we would, again, need to look at the data, the mode of birth, mode of fetal surveillance, neonatal outcomes, and maternal outcomes. And I would expect to find a reduction in C-sections with IA. And I would expect that either CEFM or IA had no effect on neonatal outcomes. And ultimately, the reduced C-section rate, the greater freedom of movement in labor, and less complications that arise with medical interventions would ultimately lead to greater patient satisfaction. And again, potential barriers to evaluation. When an adverse neonatal outcomes occurs with IA, it may be unclear whether or not CEFM could have helped. For dissemination, I could present my findings to unit leaders and propose an educational presentation to the staff. I could also present my findings to a professional nursing organization such as A1 in the top corner here, and request to speak about findings in one of their conferences. I may also publish my findings in a research journal, such as the Journal of Obstetric, Gynecologic, and Neonatal Nursing. So, in conclusion, CEFM is not associated with improved neonatal outcomes as compared to IA. CEFM is associated with a higher rate of medical interventions, including C-sections. Of course, the C-section rate, as high as it is now, the reason for this is multifactorial. And the mode of fetal surveillance is just one part of the problem to look at in order to reduce the rate. And IA has been shown to reduce the C-section rate while maintaining similar neonatal outcomes to CEFM. In my interview with an expert in my field, she told me that CEFM was originally implemented as a solution to adverse neonatal outcomes such as death or cerebral palsy. In her experience, it has not achieved this goal that it was originally intended to achieve. And she told me that it's really been a distraction from supporting the women in labor because nurses are now more focused on maintaining the strip rather than supporting the woman in the way that they used to before CEFM was implemented. So I hope that you've learned a bit more about CEFM and its relationship to the C-section rate in our country. And thank you for listening.